In the name of the Father, and the Son, and of the Son, and of the Holy Spirit. Amen. Hi, my beloved students. Today we will talk about burn. So take your papers to make the notes for your big board exams, because questions like this will be happened. You will be asked about burns on the big board exam. So let's go. Burn is not a merely skin injury. No, it's a profound physiological insult that can trigger a systemic cascade of events leading to significant morbidity and mortality. So it's defined as a tissue damage caused by excessive heat, electricity, radiation, or certain chemicals. And the most painful burns are often not the most severe ones. Second-degree burns are notoriously painful. Are notoriously painful because nerve endings in the dermis are irritated and exposed. It is exposed, snaked if you want. In contrast, full thickness third degree, God forbid, burns can be painless or have minimal sensation in the center because the nerve endings have been completely destroyed. So let's explain this phenomenon. First degree, degrees of burns. First degree, so-called superficial, involves only the epidermis, characterized by redness, so-called erythema, mild pain, and no blisters. A classic example is a mild sunburn. Second degree, so-called partial thickness, extends into the dermis. Superficial, partial thickness, affects the papillary dermis, presents with intensely painful whipping blisters and skin that blanches with pressure. Deep, painful thickness extends to the reticular dermis, appears mottled, patchy red and white, may have ruptured or intact blisters, is less painful, and may not blanch. No, with pressure. These often scar and may require skin grafting. Third degree, full thickness, destroys both the epidermis and dermis, extending into the subcutaneous fat. The skin appears leathery, waxy, white, or charred. There is no sensation and no blanching. We'll talk about third degree. All skin structures, hair follicles, sweat glands are destroyed. And finally, fourth degree, that would be it. The deepest burn extending through the skin into the underlying fascia, muscle, and even bone. What's clinical importance of that? It's actually exam importance as well. Be able to classify a burn based on a clinical description. Exam question tip. A question describing a painless, leathery, white eschar is pointing you toward a third degree burn. This absence of pain is a key diagnostic clue for deep burns. A major burn triggers a systemic inflammatory response so intense that capillaries throughout the entire body, actually not just at the burn site, become leaky. This leads to a massive fluid shift from intravascular space into the interstitial space. Large burns, typically more than 20 total body surface area, TBSA, totally body surface area, TBSA. Initiate the release of inflammatory mediators like histamine, prostaglandins, and cytokines. Cytokinesis. Anyway, so this increases systematic capillary permeability. Plasma, proteins, and electrolytes leak out of the blood vessels, causing profound intravascular volume depletion, hypovolemia, and massive tissue edema. This condition is known as a burn shock, a form of distributive and hypovolemic shock. Clinical importance. This is the most immediate life-threatening complication of major burn. Unmanaged burn shock leads to organ hypoperfusion, renal failure, and death. This is why aggressive intravenous fluid resuscitation is the absolute cornerstone of early burn management. Exam question tip. Understand that the primary goal in the first 24-48 hours is to combat burn shock with fluids, not to treat the wound itself or prevent infection. Those come later. Now about rule of nines. What is this? The rule of nines is a brilliant and rapid clinical tool for estimating TBSA, total blood surface area, of a burn in adults, but is remarkably inaccurate for children due to their different body proportions. A child's head is a marsh ladder relative to their body. So, rule of nines. Divide the adult body into the regions of 9 or multiples of 9. For example, head and neck 9%. Each arm 9, total 18%. Anterior trunk, chest, abdomen 18%. Posterior trunk, that is back, 18%. Each leg 18, each leg. So both 36%. Perineum 1%. For children, the Lund-Browder chart for children, pediatrician, is most accurate as it adjusts for age-related changes in body proportions. For small or patchy burns, the patient's palm, including fingers, is roughly 1% of their TBSA. Clinical importance of that. So I think actually examining importance as well. You must be able to calculate TBSA to determine if a patient meets criteria for transfer to a burn center, and most critically, to calculate fluid resuscitation needs using the Parkland Formula. An exam question tip. You will almost certainly be given a scenario and asked to calculate the TBSA. Remember that superficial first-degree burns are not included in the TBSA calculation for fluid resuscitation. So actually a little bit later about Parkland Formula. Anyway, determine. Sorry. So a patient, very important point, my beloveds. A patient can have minimal or no external body burns, but still die from a severe inhalation injury. So the heat, smoke, and toxic chemicals like carbon monoxide and cyanide cause direct thermal injury to the upper airway and chemical injury to the lower airway, leading to massive edema, bronchospasm, and impaired gas exchange. Inhalation injury should be suspected in any patient burned in enclosed space or with facial burns, singed nasal hairs, soot in the mouth or sputum, hoarseness or wheezing. It has three components. Upper airway injury. Thermal injury leads to severe edema that can cause complete airway obstruction within hours, sometimes minutes, even minutes. Lower airway, tracheobronchial injury. Chemical irritation from smoke particles damages the respiratory epithelium, impairs ciliary function, and leads to inflammation, mucus pluging, and acute respiratory distress syndrome, ARDS. Systemic toxicity, carbon monoxide, and cyanide are common byproducts of combustion. CO, carbon monoxide, binds to hemoglobin with more than 200 times the affinity of oxygen, causing functional anemia and cellular hypoxia. Importance of that. Inhalation injury is the leading cause of mortality in fire victims. The key is a high index of suspicion and prophylactic early intubation. Do not wait for stridor or respiratory distress to develop. By then, airway edema may make intubation impossible. Exam question 2. If a question mentions a fire in, for example, like this, in an indoor space and soot in the nares, the answer is highly likely related to securing the airway or managing inhalation injury. Electrical burns are a classic example of the iceberg, so-called, in quotes, iceberg effect. The visible skin wounds and the entry and exit points are often small and innocuous, but they hide massive deep tissue destruction along the current's path through the body. As we know, electricity current travels through the body along the path of least resistance, locus minoris resistencia, that is, nerves, blood vessels, muscles. It generates intense heat, Joule effect. Joule is a name, Joule effect, causing deep coagulation necrosis of muscles and other tissues. This leads to two major, often hidden complications. Rhabdomyolysis. Massive muscle breakdown releases myoglobin into the bloodstream, which is nephrotoxic, highly nephrotoxic, and can cause acute kidney injury, so-called acute tubular necrosis. Patients present with dark tea-color urine. Cardiac arrhythmias. The electrical current can disrupt the heart's conduction system, causing immediate ventricular fibrillation, asystole, or delayed arrhythmias. Clinical exam importance. Every patient with significant electrical burn requires a cardiac evaluation with an electrocardiogram and continuous cardiac monitoring. Actually, it's a 24-hour ECG. They also need aggressive, in this case it's absolutely correct, aggressive fluid resuscitation, often at a higher rate than just thermal burns, to flush out the myoglobin and protect the kidneys. Urine output is the key monitoring parameter. Exam question tip. For an electrical burn victim, key management steps include ECG, checking urine for myoglobin, and aggressive intravenous fluids. Chemical burns. The type of necrosis caused by acid versus alkalis is fundamentally different and dictates the severity. Okay, so we've got acid versus alkalis. Acids causes coagulation necrosis, which creates a hard, leathery eschar that tends to limit further penetration of the acid. Okay, so acid causes coagulation necrosis, which creates a hard, leathery eschar that tends to limit further penetration of the acid. Alkalis, however, causes liquefaction, I'm sorry for my pronunciation, liquefaction necrosis. So liquefaction necrosis, where tissues are essentially saponified, turned into soap, allowing the chemical to penetrate deeper and deeper and deeper, causing a more severe and progressive injury. So acid burns, hydrochloric acid for example. So the resulting Eschar walls of the injury. An important exception is hydrofluoric acid, which is extremely dangerous. The fluoride ion deeply penetrates tissues and binds calcium, causing life-threatening systemic hypocalcemia and cardiac arrhythmias. Alkali burns, for example, drain cleaners, cement, these are often more severe because they melt tissue, allowing for continued destruction until alkali is exhausted or neutralized. Importance of that. The first and most critical step in managing a chemical burn is a copious irrigation with water for at least 30-60 minutes to remove and dilute the offending agent. Do not try to neutralize the chemical with another chemical, as this can generate heat and worsen the burn. For hydrofluoric acid burns, after irrigation, treatment involves topical or injected calcium gluconate to bind the free fluoride ions. Now, exam question tip. For a chemical burn, the answer is always irrigation, and irrigation. Yeah. About Parkland Formula. So the Parkland Formula, the gold standard for burning resuscitation, times the fluid administration from the moment of the injury, not from the time of hospital arrival, from the moment of the injury. This is a common point of error in clinical practice. So the Parkland Formula calculates the amount of intravenous fluid needed over the first 24 hours. Formula, right. 4 milliliter per patient's weight in kilograms, multiply, 40 milliliter multiply patient's weight in kilogram, multiply in percent, TBSA of burn. Fluid of choice is a ringer. Lactated ringer, sometimes pronounced ringers, solution, LR solution, lactate ringer solution. It's a balanced isotonic crystalloid that most closely resembles the body's extracellular fluid and helps buffer the metabolic acidosis common in burn patients. So how to administrate? Good question. Give the first half of the total calculated over the first 8 hours. So first half in the first 8 hours, given the second half of the total volume over the next 16 hours. So you must know this formula and how to apply it. If it's only the most, it's one of the most frequently tested question calculations in emergency medicine and surgery. Now, for example, a 70 kilogram man sustained clinical example. A 70 kilogram man sustained 40% of TBSA burns at 8 a.m. and he arrives at your hospital at 10 a.m. Calculate his fluid rate for the first 8 hours. Now calculation 4, Parkland Formula, multiply by 70 is weight, and multiple 40 TBSA. We've got 11,200 milliliter total. First half 5 and 6,000. Time, the first 8 hours end at 4 p.m. So he arrived at 10 a.m. So you have just 6 hours from 10 to 4 to give 5,600 milliliters. The rate 5,600 divided by 6 hours, something like 933 milliliter per hour. Okay, like this. So post-burn hypermetabolic response. Following a major burn, the body enters the most profound hypermetabolic and hypercetabolic state known as in human physiology, far exceeding that of a major trauma or sepsis. major trauma or sepsis. The resting metabolic rate can up to 200% of a normal. A massive and sustained surge of catecholamines, epinephrine, norepinephrine, and cortisol drives this response. This metabolic firestorm, actually a metabolic firestorm, leads to extreme muscle breakdown, catabolism for energy, hyperglycemia due to insulin resistance, increased body temperature, massive energy expenditure, massive energy expenditure. This state can persist for up to a year after initial injury, leading to severe muscle wasting, immune suppression, and poor wound healing. The importance of that. Early and aggressive nutritional support is critical to mitigate this response. Enteral feeding, tube feeding, is preferred to maintain gut integrity. High protein, high calorie diets, so I repeat, enteral feeding, that is tube feeding, is preferred to maintain gut integrity. High protein, high calorie diets are essential. Medications like beta blockers, no, it's a classic, it's a propranolol, may be used to blunt the catecholamine-driven hypermetabolic response. An exam question tip: understand that nutritional support is alive with water, liquid resuscitation. Understand that nutritional support is a life-saving as a fluid resuscitation is the long-term management of burn patients. In the long term of burn patients. Okay? So escharotomy versus fasciotomy. Escharotomy is an incision made only through the burn skin. Eschar. And does not require sterile operating room or anesthesia, as the full thickness burn has already destroyed the nerve endings. Fasciotomy is a much deeper incision through the fascia and is a formal surgical procedure. Yeah. Escharotomy, a full thickness circumferential burn, one that goes all the way around the lip or the chest, acts like a tourniquet. As edema develops underneath this inelastic, leathery eschar, it can cut off blood flow to limb, causing ischemia, or restrict breathing if on the chest. An escharotomy is a bedside procedure to incise the scar and relieve this pressure. Fasciotomy, and this procedure is to treat compartment syndrome, which occurs when pressure builds up with a deep muscle compartment bound by fascia. This is the most common in high voltage electrical burns or deep thermal burns that cause significant muscle damage. The importance of that, be able to differentiate the two. Exam question. Tip: a question describing a circumferential full thickness burn with absent distal pulses and a cool pale lump is asking for an escharotomy. A question describing a deep electrical burn with a tense, swollen muscle compartment and pain or passive stretch is asking for fasciotomy. About infection. After the initial period of burn shock is managed, the leading cause of death in burn patients is infection and sepsis. The burn wound is a perfect culture medium. It's warm, moist, protein-rich, and its primary defense, the skin barrier, is gone. So, ideally, the burn eschar is initially sterile, but it's quickly colonized by bacteria, first from the patient's own skin and gastrointestinal flora, and later from the hospital environment. The patient's immune system is also severely suppressed by the burn injury. Common culprits include Staphylococcus aureus, Pseudomonas aeruginosa, notorious for its greenish exudate and fruity odor, and Acinetobacter baumannii. The importance of that. Meticulous wound care is a paramount. This includes regular cleaning, debridement, that is removal of that tissue, debridement, and the application of topical antimicrobial agents, for example, silver, sulfadazine, mefenite, acetate. Systemic antibiotics are reserved for documented infections, not for prophylaxis, to prevent resistance. An exam question tip: be aware of the common burn wound pathogens. If a question mentions a burn wound with a sickly sweet smell or greeny blue discoloration, think Pseudomonas aeruginosa. The majority of permanent tissue damage in severe frostbite doesn't occur during the initial freezing phase, but during the rewarming phase. This is known as a reperfusion injury, a concept shared with heart attacks and strokes. So, frostbite is tissue injury from freezing. The process has two stages of damage. Direct cellular injury, so-called freezing phase. It's so ice crystals form both inside and outside the cells, physically piercing membranes and causing cell death. Blood vessels constrict, vasoconstriction, to conserve core body heat, further starving the tissue of oxygen. Second, indirect injury, thawing, reperfusion phase. As the tissue is rewarmed, blood flow returns to the damaged area. This seemingly positive event unleashes a devastating inflammatory cascade. Damaged blood vessels leak fluid, causing massive swelling. The process releases inflammatory mediators like prostaglandins and thromboxanes and oxygen-free radicals, which leads to blood clot formation, thrombosis, in small vessels, cutting off blood supply again and causing far more extensive cell death than the initial freeze. Importance of that. Clinical and exam. Understanding reperfusion injury is key to modern frostbite management. Treatment is aimed at mitigating this secondary damage. This is why non-steroidal anti-inflammatory drugs and NSAIDs, like ibuprofen or aspirin, are given immediately to block the prostaglandin pathway. In severe cases, thrombolytic therapy, clot-busting drugs, may be considered to restore blood flows. An exam question. Tip. A question about the pathophysiology of frostbite will likely focus on reperfusion injury as the primary cause of tissue loss, not the initial ice crystal formation. And that's why we've got thawing protocol. So the thawing protocol. The single most damaging action you can take on a frostbitten limb is to rewarm it and then allow to refreeze. This freeze-thaw-refreeze cycle causes near complete destruction of the tissue's microvasculature, making tissue loss almost inevitable. So management is highly specific and counterintuitive. What absolute don't? Do not rub the area with snow or hands. The ice crystals in the tissue will act like shards of glass, causing massive mechanical damage. Okay, so ice crystals in the tissue will act like shards of glass, and they provoke massive mechanical damage. Next, do not use dry heat, like a fire, heater, or exhaust pipe. The area is numb, anesthetic, and the patient can easily sustain a severe thermal burn on top of the frostbite. Do not rewarm in the field.
if there is any chance of refreezing during evacuation. It's better to walk on a frozen foot than a thawed, painful and swollen one. Definitive do's in controlled hospital setting. Rapid rewarming. The cornerstone of treatment is immersing the affected part in a circulating water bath with a carefully controlled temperature, 30 degrees Celsius. That is 98.6, 102.2 Fahrenheit, for 15-30 minutes or until the tissue is pliable and red. Rewarming is, remember, pain management. Rewarming is excruciatingly painful. Aggressive pain control with parenteral opioids is required. Wound care. After rewarming, the limb should be elevated to reduce swelling. Clear blisters are often left intact, while hemorrhagic bloody blisters may be debrided as they indicate deeper injury. Tetanus prophylaxis must be administered. You must know the rules of rewarming, my beloveds. Exam questions love to present a field scenario. For example, a lost mountaineer, to test your judgment about when and how to rewarm. An exam question tip: differentiating frostbite degrees is key. Clear or milky blisters appear in second-degree frostbite. Hemorrhagic, blood-filled blisters signify once again, clear or milky blisters appear in second-degree frostbite. Hemorrhagic blood-filled blisters signify deeper third-degree injury and a worse prognosis. Well, largely sufficient, I suppose. So that's enough. Thanks for your attention. Don't forget, my beloveds, to follow and subscribe my Dr. Y YouTube channel, as well as my private Telegram channel, Dr. Y. It's a private. It's not costly at all. Dr. WHY. So you type in searching mode in Telegram, Dr. Y, Dr. WHY, no, without question mark, of course. You click start and choose your plan. Stay blessed.